Good morning, and thank you for joining me and the STEPP team today for this presentation on the effective use of quit kits for promotion, engagement, and action. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. I'll be kicking things off today, and then after I've said my piece, I'm going to turn the mic over to the STEPP team, who will be sharing the updated guidance and where you can find those documents. I will be cameras off during this presentation portion of today's learning community call, but we will have time for Q&A afterward. And at that point, I'll be turning my camera on, and I hope you do as well. There, I have a couple people whose mics I'm going to mute here. And just as a note, today's recording is being recorded. And so if you need to refer back to anything, you can. And of course, I have the slide deck as well if you want to return to that. All right. So before we dive into quit kits, their component parts, and whether and where they may be effective, it's worth talking about some basics about where our knowledge base is regarding nicotine recovery. And before we do that, I do want to offer a word of caution. Our understanding of addiction as a compound biological and psychological disease, if you buy the disease model, has really only emerged in the latter half of the 20th century, with significant advances only in the last few decades. It was only in the 1980s that scientists could undeniably confirm that nicotine was the primary driver of addiction in tobacco products. The 1980s. I was alive for this. And here I do want to repeat and stress the word undeniably, because nicotine, being the prominent alkaloid in the tobacco plant, and alkaloids having long been isolated and extracted from plants for medicinal and recreational use, it already had a lot of scientific evidence pointing to it as the main culprit. Still, tobacco companies maintained a front of plausible deniability, which you can see on the slide, until the publicly available scientific evidence was absolutely unquestionable in this regard. So why do I bring that up? Well, what this means is that despite a century or more of investigations into the nature of addiction, there still remain a lot of mysteries. And the ability to scientifically study cessation interventions is confounded on multiple fronts.
I was trying to respond, and I was like,
oh my gosh. To provide insight into the nature of this talk on the effective use of quit kits, I think it will be best to spend a little bit of time talking about what quit kits are neither good nor efficient at. Namely, they are at best inefficient cessation aids, and at worst, they may not be effective at all. And it's important that we start here because quit kits are and have been a common tool used by governments, nonprofits, and advocacy groups to promote cessation. And while the possibility that they may be useful for that purpose remains, the evidence to support that belief is scant. But it isn't just that there is little to no evidence that they are good cessation aids. This entire introduction is a long lead up to say that there's very little reason to believe that they would be an effective cessation intervention, given what we know about the nature of addiction and the difficulties of recovery, specifically from nicotine. Nicotine is a rapidly metabolized psychoactive drug. In several measures of addictiveness and harm, there is broad agreement from experts that nicotine is among the most addictive and deadly drugs on Earth. Measured by capture rates, that is, the amount of individuals who use recreationally who will go on to develop a problematic habit, it's about as addictive as methamphetamine. As measured by the odds of a successful recovery per quit attempt, it's about as addictive as heroin. In fact, many individuals who have successfully recovered from alcohol or another drug either do not attempt to recover from nicotine or they fail to do so. And many individuals who have recovered from alcohol or other drugs and nicotine report that nicotine was the hardest of the drugs that they recovered from. And there's good reason for that we can talk about on a different day, and that I have actually talked about in this forum quite a bit. The point here is that nicotine is an addictive drug, and its most addictive form is inhaled into the lungs in short bursts throughout the day. And the most popular way to do that for older adults is through combustible cigarettes, and for younger adults and adolescents through vaping. Given how addictive nicotine has proven to be, it is a tad odd in my opinion, that we should ever think that a handful of inexpensive and readily available trinkets and candy would somehow combat an addiction of this magnitude. Nevertheless, quit kits are a common tool, and they have proven to have some value, although what their value is and how valuable it is complicated to discover. In order to talk about what a quit kit does or does not do, I want to do two things. I want to talk about what a quit kit is, and I want to talk about two studies that I think make the best possible case for using quit kits so that we can talk about what the researchers in those studies found and how, contrary to their summary of their results, their findings actually offer something of a warning for using these as cessation aids and actually make the case for something else. So I don't want to propose like an official definition of what a quit kit is or should be. Rather, I want to offer a simple generalization of the quit kits that I've encountered, and I want to break that generalization into three parts: what I'm calling the what, the why, and the who. Right? A quit kit. Here we go. If I can make the animation happen. The quit kit. A quit kit is a collection of items intended to promote cessation among those who receive that quit kit. And I think that we can further specify that in general, the quit kit is intended to be given to tobacco users, primarily cigarette smokers and ends users, as many of the items inside are often geared at those who smoke or vape, like straws or toothpicks to satisfy oral-related urges during the quit attempt. The items that we choose to go inside explain the how. The items that comprise the quit kit tend to be of two main types: items that educate, inform, or raise awareness about tobacco use and cessation and things, and then there are other things designed to mitigate cravings and other symptoms of withdrawal. And that's what I would call the fun stuff that's in a quit kit. In my experience, when folks are asking me for advice on what to put in a quit kit, they're often asking me for advice on the fun stuff. For example, like, have I heard as a researcher that cinnamon gum is better than mint, or are cough drops and lozenges better than gum? What about mint snuff? Are stress balls better than detanglers? Has anybody done a study on the effectiveness of fidget spinners? What about handheld puzzles, etc.? And it is on this point that we should be really, really clear. If these things matter at all, the effect is not observable given the predicted effect of the other items in the quit kit, which are those printed educational materials. And just to clarify, when I say, quote, the effect of the fun stuff is undetectable given the predicted effect of the educational items, I mean the cessation outcomes. There are potentially a lot of other effects of the gums and the squeeze balls and the mini etch-a-sketches that you might give away that are beneficial and potentially worth pursuing, but those are not cessation effects. We'll talk more about that coming up, but for now, I want to present the two case studies that I mentioned. So between January and March 2010, so this is a little while ago now, 480,000 quit kits were distributed in the UK. The contents of the quit kits were determined in a multi-stage process the previous year. And those items were a health and wealth wheel, a Tangle stress reliever, a quit plan wall chart with stickers, which included how to set a quit date on it, a willpower assessment quiz, information regarding local, what is essentially their quit line type service, motivational postcards, because this was done in the UK, a toothbrush, and information on stress management, which was available as downloads, like on a flash drive. Now, about 2,300 folks were interviewed after these 480,000 quit kits went out, and these are the results from that first survey. Now, generally, these results at first glance are extremely positive. And even after the scrutiny that I'm about to subject these statistics to, I think they retain a pretty strong glow about them. But what they don't show is strong evidence for use as a cessation device. And we'll return to cessation rates in a little bit. However, there is strong evidence that the quit kits, one, captured and maybe even drove up motivation. Now, that's hard to determine. And as an end goal, I would suggest that raising motivation isn't really a sufficient end goal. However, as we'll see later, it also drove up engagement with the services, and that is a good end goal. Two, it also generally had a positive impact on people's attitudes towards the UK's Stop Smoking Services offices. Three, It seems to have had an impact on confidence, which is a great thing, and for the people like the quit kits, which is also really awesome. And that's an important first step that fosters further action. Now, the second case study I want to talk about is actually just a refinement of the first one. So to the first quit kits already described and based on user feedback, the researchers added a quit planner, graphic health warning cards, and a voucher for 1 free week of nicotine replacement therapy. And here are the results of that survey. Interestingly, the researchers note that individuals who picked up their quit kits from a pharmacy, those that picked them up in person, were much more likely to quit compared to those who ordered theirs online. And this could be an effect of engaging with a local trusted healthcare provider. Some of you may know that I have done a lot of work with pharmacies. But to me, this is probably actually more a reflection of the motivation of the users. It is very easy to simply order a kit online. It is easy, but harder to go in person to pick one up. So on net, the pool of people who go into a store are probably just more committed to their quit plan compared to the ones who ordered online. Adding to that, researchers also found, I love this statistic, researchers also found that overall, 69% of individuals who received a quit kit redeemed their nicotine replacement therapy voucher. I think that's awesome. But among the 561 individuals who picked up their kits from the pharmacy, that figure was 92%, 92.8% to be precise. So almost 93%. As you might suspect, I, like you, read a lot of studies about tobacco control and nicotine cessation, and I have found that researchers seem to really undervalue the role of motivation in quitting. Motivation matters. It determines whether or not someone tries to quit. It determines how much and what type of assistance they seek out, a point I'll return to in a second, and it mediates the chances of continuous abstinence or relapse. So now I kind of want to talk about these two studies combined, and specifically calling attention to their abstinence rates, which are now pictured at the bottom of the chart. In the first study, the Quit Kit 1, the QK1 column, half of recipients tried to quit after 1 month, an astounding figure. When the researchers limited their analysis to just those who could have possibly been quit for a month, so they've had a quit kit for the full month, 26.5% of recipients had been quit for at least 1 month. In the second study, the QK2 column, 3/4 of recipients had tried to quit, and 31.5% of individuals who had had their quit kits for a month had been quit for a month. Now, these are 1 month measures, but 6 months is a better follow-up one. And what we know from other studies is that about half of those who are quit at 30 days are still quit at 180 days. So we can assume, and I think without being unfair, that these numbers are really more like 13 and 16%. That's actually still pretty good numbers for a low intensity intervention like this. However, here are the 6-month figures from a meta-analysis from 2000 to 2008, which was it was originally developed in 2000. It was updated in 2008, and this is what you'll find in the Treating Tobacco Dependence Manual. And if you don't have that, please let me know, and I will email you a PDF version of it. It is the foundation of this work. And what you can see here, I'll just circle it, is that at 13 and 16%, these quit kits are about where we would expect for self-help materials, which is in fact what these quit kits were. And self-help materials are the educational pieces, the marketing materials, and typically some kind of structured instruction, like listing motivations, dependent self-assessments, and how to set a quit date. Now, this slide is pretty old. Like I said, it's from 2008. So I don't like to use it too much anymore, but the studies in question, the 2 case studies, are from about the same time period when this chart was made. However, one thing I do like to point out when I do use this slide is the jump from unaided quit attempts at a 4 to 7% success rate up to self-help at 11 to 14%, which means that using self-help materials basically doubles the chances that a person will successfully succeed. So the question that we'd have still to ask is, what motivates somebody who has in their possession some self-help materials to use them? That is the puzzle that these quit kits propose. So let's briefly move away from quit kits, whose effectiveness as a cessation tool we are trying to discover, toward those interventions that have been shown to work in multiple populations across multiple studies over many years. And we'll see if we can suss out a potential role for quit kits. So listed here are the tobacco cessation interventions that receive a letter grade of A from the United States Preventive Services Task Force. These are what we consider the evidence-based tobacco cessation interventions. And in this box, I've broken out 3 actions that are necessary but insufficient to promote us or support a quit attempt. I broke these out because they can be done in a standalone or isolated fashion and will promote or support a quit attempt so long as they are connected to the provision of one of the bulleted items. And you will note that education and assessments are in the box. And both of these can be and probably should be added to quit kits. But we can also add other things to this box. Right? And these are things that we've already discussed as showing up in the quit kits that we studied in the case studies. So we have, I think, covered that whether we are talking about cinnamon flavored toothpicks and stress balls or printed structured guidance, quit kits are not in and of themselves cessation aids. They become cessation aids when they are motivation to connect people to resources, cessation interventions themselves. All right, so let's get into it a little bit more. At this point, I'm going to start encroaching upon material that shows up in the guidance document. So when we're designing a quit kit program, we always have to keep our audience in mind. And I think there are 3 main audiences. First, and obviously, are the tobacco users, the people that we would like to have quit tobacco. Related to this first main audience are the friends and families of potential quitters. And I don't have any particular advice about this potential audience, like whether you should tailor a quit kit to be attractive to them. But I will say this, the messages that tobacco use is addictive or that nicotine is addictive, that chemicals in many tobacco products are known to cause disease, and that quitting is possible, all of those things have been said before, and they will continue to be said for the foreseeable future. So often it's not what is said, but who says it. And friends and family are just naturally going to be more persuasive than public health departments. We also know that people who do obtain, we also know that people do obtain quit attempts for the tobacco users in their life. So we should know that some of our quit kits are likely going to be seen first by those individuals. The second or third main audience are our community partners. And we can divide our community partners into 2 main groups, those that may refer to clinical interventions and those who provide those clinical interventions. And sometimes some people are both, right? Like a doctor can provide an intervention and also make a referral to a quit line. Right. And so then once we have the quit kits, they really have 3 main functions that are modulated by who that audience, who that recipient is. And that first function is fundamental. We should consider all quit kits to have a promotional capacity. The contents of quit kits are for the tobacco user. So all quit kits should contain information on available cessation resources, specifically the Colorado Quit Line, but also local substance abuse treatment centers, local tobacco treatment specialists that exist at hospitals and clinics, the availability of NRT at their local pharmacies. Those are just examples. You don't necessarily want to overwhelm folks with a phone book of resources, so you can exercise some curation here. Now, while all the content of quit kits are aimed at the tobacco user, if the target of a quit kit program is to engage with, if that's the objective, is to engage with community partners, then we use the opportunity of designing and delivering the quit kit to promote other things as well. For potential community partners like local businesses, you may also want to alert them to the existence of local resources, including local treatment providers. For the providers themselves, you may use the quit kits to highlight best practices in making referrals to the quit line. You might also want to raise awareness of local services that might serve as supplements to a quit attempt, like local gyms and yoga studios, any recreational facilities that exist, including especially any that are free, and also point out, highlight safe walking and biking paths. If there are other at your local community hub, if there are financial management courses, or if there's other substance use treatment options, you'd want to highlight any and all of those. All of these promotional awareness raising content All of that should be aimed at the quitters. However, the more interesting the content is, the more enticing your community partners will find it, and the more likely it is that they will join you in distributing those quit kits. So use the opportunity of delivering or shipping your quit kits to clinicians and other community partners to educate them on the resources inside so that they can more effectively engage with patients or clients that they give the quit kits to. So we're really hedging in and moving in toward engagement, the second main function of a quit kit. And here we need to distinguish between using quit kits to engage with our community partners and build those partnerships, and quit kits being used to engage recipients in their quit attempts. So I'm going to spend some time on this, probably in a little bit more detail in a minute. The truth is that whether with tobacco users or with community partners, the primary objective of the quit kit is really engagement. Your engagement with your community partners and getting the recipients of those quit kits to engage with interventions. Oh, and then finally, of course, there remains the self-help purpose, the original purpose of the quit kit, to aid in recovery, primarily by mitigating withdrawal and providing instructions for making a quit plan. Now, I spent the first half of this webinar saying that this is where the evidence that they work is somewhat lacking. And I'd add to that this is also where our ability to measure the success of our quit kits is really quite low. I don't want to imply that the content simply doesn't matter at all. If the point of the quit kit is to engage, then the content has to be interesting, right? In the case of direct delivery to tobacco users, the content should be perceived as useful directly to them. In the case of delivery to care providers, they should perceive the content as useful enough for their clients that they're willing to engage their clients in a conversation about their quit attempts. So I do want to talk a little bit more about engagement, because this is really where the action is. If I can get the slide to advance. There we go. So I want to go back to the case studies. I said about 10 minutes ago or so that there was really one interesting thing that these two studies shared, and then I never brought it up again. And that is this. After quit kit 1 was sent out, quote, as a consequence of receiving the quit kit, 29% of interviewees reported visiting their doctor, and 17% reported visiting their pharmacist about quitting. Additionally, 24% reported looking up details of their local Stop Smoking Services office. 13% said they had contacted the SSS, and 11% reported visiting them. That's amazing. And after quit kit 2, quote, visits to the pharmacy and doctor regarding quitting were reported by 11.1% and 15.5% of respondents, respectively. Also amazing. And that doesn't include about a third of the nicotine replacement users, the nicotine replacement therapy users, who went to their pharmacist to get more, and another 15.6% who had more prescribed for them. Which is all to say that the quit kit, whether that was the intention of this program or not, engaged these users with public health and medical professionals as part of their quit attempt. And that quit attempt was potentially inspired by receiving the quit kit to start with, which is to say, engagement matters here. That was the real success of these programs, not the cessation numbers, which were more or less in line with what we would expect them to have done. All right. So one final note for me, and this is on data when you're thinking about how to deploy your quit kits and measure their success. It is incumbent on each of us to make sure that the money we spend on tobacco work has the desired effects. Obviously, all programs are going to have some non-effects, right? You're going to have flyers that are thrown away, quit kits that stay on people's shelves unopened. But the bottom line is that good intentions here aren't enough. We can't just send quit kits out into the world without attempting to find out if it's doing what it's supposed to do out there. And of course, whether or not there's opportunities to make it do its job better. I think the possibilities here are only limited by our imaginations. So rather than talk about specific ideas of how we can measure our impact, I thought I would just mention some guidelines, which are on the slide here. The first thing I would do when thinking about how to measure the impact of my quit kit program is to think about and list all the things in the program that can be counted. Counts are normally pretty easy to discover, and they are often pretty easy to affect with simple program adjustments. Did you give out 250 quit kits this year? Can you make it 300 next year? But just because you can count a thing doesn't necessarily mean you should. Some things you can count may be out of your power to control. For example, if you want to count how many quick kits get in the hands of actual users, but you yourself, your program are only handing them out to clinics, then you exercise less control over whether or not they get into the hands of those final users. And it could be out of the clinic's control if they are already maximizing their distribution. If they're already giving these out to 100% of positively screened tobacco users, then they also can't change their number. So count the things that you do, that is, I was stressed it the right way, and maybe limit it to the things that you can theoretically change. I also want to stress that engagement is our number one target here, and engagement has inherently qualitative attributes. So I definitely would encourage you to try to measure or report really basic things like the number of conversations that you've had because of your quit kits, the length of those conversations, and any follow-up actions from those conversations. And also, don't forget to try and find out how people felt about those conversations, whether attitudes changed about the possibility of quitting or even about the esteem that they hold your office in. And that does it for me. I'm going to hand it over to Tiffany and the Cessation team, although I do have to hand over control. I have to promote Tiffany. Tiffany, is it going to be you who has the slides, or is it going to be somebody else? So I should promote to co-host here.
It'll be Chelsea.
Chelsea. Okay, great. Chelsea, you are now a co-host, and you can share any slides that you may have.
Cool. Thank you, Jim.
Absolutely.
All right. Can everyone see my screen? Cool. Yes. Well, thank you, Jim. A lot of this presentation is going to be a little repetitive. So first, I just want to introduce myself. I am Chelsea Casillas. I am the Tobacco Treatment Initiative Specialist on the STEPP team in the Cessation pillar. I am pretty new. I started July 1, so this is actually my first presentation. So we're just going to talk about quit kit guidance that the STEPP team has kind of created along with Jim. And so I first want to kind of touch on quit being in quotes right now. So some research has shown that quit can sometimes be a deterrent or is a very definitive statement. And so we are working on trying to rename this. We have no idea what to do with it, but on the last slide, we'll have options for feedback. So get those gears grinding about what you think the quit kit could be renamed to. So what are quit kits? There really is no standard definition, like Jim said. It really is a collection of items intended to help a person to end or reduce their nicotine use. It is not an evidence-based cessation strategy, so we cannot say that it is proven to help with or to move towards cessation, but we can say that it plays a supporting role in raising awareness and then also encouraging those to connect to tobacco treatment. There are specific objectives, like Jim also stated, that need to be met for quit kits to be approved. And it's those three objectives. It being a promotional tool, it being an engagement tool, and then also it being a self-help resource. So as an engagement tool, this is really used to build and strengthen relationships with community partners. So this can mean a lot of things, tailoring kits for clinicians or healthcare settings to maybe just encourage conversations about tobacco treatment. And then it can also be used as a self-help resource for people trying to quit or reduce their nicotine use. And like Jim also stated, that self-help guides have been shown to help more people quit than no intervention at all. So the STEP team, along with Jim, has also created this grantee quit kit guidance that is linked here. It is kind of just basically a Word doc of everything that I'm going over in this presentation. It's a really good resource to refer to when maybe you or your agency is starting to create some quit kits. Okay, so better practices for use. When you are creating your quit kits, we want to make sure that you're following along with basically a little checklist that we have. So identifying your objectives. How does this quit kit align with your current implementation plan? Does this quit kit maybe complement or help advance a current activity or strategy that you're already working on? Understanding your audience. So who is this quit kit for? Who will it go to? Whether it's going to be navigators, coaches, healthcare professionals, and then pairing with a process to connect to evidence-based cessation services. So encouraging those partner organizations to refer clients to those resources, and then incorporating current resources. So resources that you have access to already, whether it's co-health resources. This also depends on your audience. So are you going to have youth resources? And you should have a lot of access to all those. And that will also be in the quit kit guidance form that I referred to last slide. So items in a quit kit. This is just a quick overview of required items, optional items, and then items that are prohibited. So required items, that is the ALA Freedom from Smoking, the guide to help you quit. So this is currently the best evidence-based resource that we have to put in a quit kit at the moment. This is going to come out of your budget. If budget is a concern, there will be a free resource that will come out in the next grant cycle that will be accessible to you. But for now, this is what is required, and it is going to come out of your budget. And I'll talk about how to do that on the next slide. And then what's also required is the Colorado Quit Line resources, as well as the quit kit items checklist. And what this is going to be is just a little postcard that kind of gives an overview of what the items in the quit kit, basically what their purpose is in the quit kit. And then some optional items that you can put in your quit kit: sugar-free candy or gum, fidget toys, water bottles, toothpicks, coupons to local businesses, like Jim stated, maybe like a coupon to half off gym membership, something related to that, and creating like a healthier lifestyle. And then at the end of this presentation, if you have any questions or any other ideas of things that maybe you have put in a quick kit, that is something that you can share at the end. And then items that are prohibited: tobacco or nicotine products, non-nicotine vapes, nicotine replacement products, essential oils, items that do not directly support nicotine cessation, and faith-based materials. So with the faith-based material, we know that we do have some grantees that do work with faith-based organizations. So what we're wanting is that A35 funds do not go toward purchasing these faith-based materials, but you can include them in your quit kit if it makes sense. Okay. And what is this approval process? So first, we ask that you discuss these plans for your quit kit with your project officer. And then you'll be able to submit a request form. This is just a Google form that your project officer should have and you should have access to. And then you're going to fill out that form. It's basically just asking a little more clarification on what you're using this quit kit for, if it's for a specific event or intervention, and then what your budget is for quit kits. Ensure that relevant language is included in your implementation plan. And then items may only be purchased after your request form is approved and after you have that conversation with your project officer. I see the chat is going crazy, but I'm just going to keep going. So some questions to consider. And this goes a bit in hand with what Jim had talked about measuring success. This is really the most important, right? So we want to make sure that these quick kits are helping those that need the resources or want to take that first step to be able to have a nicotine-free life. Did use of quit kits increase the number of engaged partners? Did use of kits help maintain existing partnerships? How? Did use of kits lead to additional engagement opportunities? And how are kits impacting patient engagement and referral to treatment in clinical settings? Okay. And that is all that I had. So this is really just a time for feedback, questions, comments, just a few prompts here. Do you have any experiences with quit kits this funding cycle? What are those? Feel free to share. Are there any reactions to the proposed changes that we have? Input on proposed changes and maybe ideas for alternative names for quit kits?
Thank you, Chelsea. That was great. So yeah, it's y'all's show now. What questions or concerns are popping up for you?
Hey everyone, this is Grace with Public Health. Not Public Health, with San Miguel County Public Health over in Telluride. I guess looking at the list of the required, optional, prohibited for the engagement quick kits, the 3 required items, is that something that as West Central or as an independent group, right, do we have to develop the checklist ourselves, or is there a standardized document that everybody in STEPP will be utilizing?
That's a great question. I'm Tiffany. I'm the tobacco cessation manager on STEPP, for those who don't know me. We are actually in the process of creating that form ourselves. Jim did a great job. This will basically just be a guide to what's in the quit kit. So rather than handing somebody a bag to say, stop smoking, and there's all these unrelated items to tobacco and people wondering, what on earth am I supposed to do with a fidget spinner and how does it relate to my cessation journey? Jim has listed out what the items are and how they can be used in the cessation process. So we are currently in the process of working with our media partners to create a customizable form where basically you can just check, yep, I want to include this, I want to include this, I'm not going to include this, so I'm not going to check that. And then a customized PDF will be created for you. So you don't have to create anything. You don't have to come up with this language. Quite literally, what you'll do is you'll just check the boxes that of the items that you want to include. We're trying to make it customizable in a way that you can add your own logos, and then you can print those yourself or send them to a printer.
Awesome, thank you. That makes a lot of sense and seems very efficient. Appreciate that. Just a follow-up question on that, and I don't know, I joined late, so I don't know if you've mentioned this already, but what is the rollout timeline to move forward with this strategy in STEPP?
As soon as possible. So I'm gonna say by January 1st, I want it well before that. So we've created these documents. What we're looking for today is just input so that if there are changes, we're not going back to the drawing board. So we're hoping to get it out as soon as possible. As someone mentioned previously, the ALA books that we're using right now as a requirement, that's what makes these quick kits evidence-based. And Jim and Chelsea talked about that. They're the best tool that we have at the moment. We actually have asked Jim and his team to create our own Colorado-focused self-help guide, which will eventually replace the ALA books. And those will be available in both a QR code and in printed materials. So that is a task that we are asking of Jim and his team. So there will not be a cost associated with that once those books are created. Until that time, the ALA Freedom from Smoking Guide is a stopgap, because we as the cessation team and Jim feel that that's the best tool that's currently available. Unfortunately, it's not available as a PDF or in a digital copy that we're aware of at the moment. And I will state, we are currently talking to the American Lung Association to try to negotiate a smaller cost, because those books are costly. So if you're doing a big event, $6 a book is pretty expensive. So we are currently in negotiations with ALA to try to drop that cost. And as Chelsea said, if it is cost prohibitive with your budget, please reach out to us and let us know. We also know that some grantees have the money to spend and they struggle to spend their budget. So we're trying to find that balance.
And I'll say that this is a good time to invite you all, that if you have run across these self-help materials and you like certain aspects of them, you hate certain aspects of them, you're thinking about using them, you're going to ask me about them anyway, send them to me, because my team will be reviewing all of the ones that we can get our hands on to figure out what we like and don't like about them, to make one that we think is going to be the best for Coloradans.
Deb, did you have a question?
Oh yeah, sorry, Deb, I saw that.
Yes, thank you. I just had a comment on Jim's presentation that he didn't note when he was talking, but jumped out at me. It was the slide that he doesn't like because it's outdated. But right below where it was talking about self-help, just below that was the quit line.
Yep.
And the numbers between the two were not all that different.
Well, and that's one of the reasons I don't like that slide, because of all the things that are going to change when that finally gets updated. It's going to be the quit line numbers. The quit line in 2008 and the quit line in 2024 are different animals, and they are about almost three times more effective today than they were back then. Quit lines are now hitting around 30 to 40% success rates, as opposed to 18 to 20, whatever it said back then. So that's one of the reasons I do not like that chart. So thank you for bringing it up and giving me an opportunity to say that quit lines are awesome, and you should be referring your smokers and vapors to it, and your SLT users as well, and your heat not burn users.
Jim, that was the best moment of my day. I think I can call it a day. I love the shout out. Thanks so much.
Absolutely. Thanks for joining, Katie.
Yeah.
So if you have quit line questions, Katie's here. Although we are going to be talking quit line at the next one of these learning community calls.
Great.
So
Let's connect, Jim, because we have some new stuff. Of course, new stuff always coming out. So
let's do it.
Hey, you guys, this is Tiffany County, Buena Vista. I put this in the chat, but in case you didn't see it, I was just wondering if you guys had just a dollar amount approximation per quit kit. I get it's in progress, and I appreciate hearing that update. I also get that it may vary depending on what items we choose to include, but for the purposes of the next draft budget due on September 6th, it'd be nice to just have an approximate amount per quit kit that we can be working off of.
That's a great question. Per quit kit, Jim, I don't know if you have numbers just anecdotally from previous positions where I put together quit kits for patients. I would budget around, with the books being $6. Now I would budget between $8 and $10. And that's for bags. Again, if your organization already has bags available or some sort of something to put them in. And then quit line materials, if you want to order quit line materials yourself through a printer, you're happy to do that. And all of this information will be in one package. You don't have to go to all these different links. So on the quit request form, which is a Google form, we'll have link outs to all of these things. So please do not feel as though you have to bookmark these items. But our quit line materials, we offer many different brochures to fit your particular population. There's some that are focused on the LGBTQI community, different priority populations. There's My Life, My Quit materials. Some of them you can print yourself if you and your organization have a great printing capability. If you don't at all, you can send them to a printer, and that's included in your budget as well. So we try to make this as customizable as possible, depending on what your population need is, how many bags you need, what event you're trying to focus, or a population you're trying to target with these bags. But right now, I would budget between $8 and $10, which seems like a lot. Again, we're trying to negotiate with ALA to get the cost of those books down.
Yeah, I think that's about right. And I think if what you want to do is, in my opinion, is start with your budget. Go shop for the things that you want in there. Look at what that is, and then see if you can get sponsorships. Because a lot of your local agencies, like I saw somebody say, "Oh, we use lip balms," and a lot of times you can get like generic lip balms that you can have your own wraparound label. So maybe your local CVS wants to put promotional CVS lip balm in there, and the CVS is in there because they also sell nicotine replacement therapy, right? They're like, find those local businesses. CVS is a bad example of a local business, but find those local businesses, your local gyms that want to add promotional materials, and see if they won't sponsor some of the tchotchke type materials as well. A squeezy ball is great, but a squeezy ball that has the local gym on it is better, and because they're paying for it.
Broomfield County actually did a great event this spring, I believe, that they worked with their local rec center, and if this was youth focused, but if youth turned in an e-cig or a vape device to them, they would give them a card for a week, I think a week's admission to the local rec center. So that's just one example.
Susan, who is a professional after my own heart, has asked ChatGPT for some replacement terms for quit kits, and some of these are pretty good. Freedom kit is good. Tobacco-free survival kit. I think that already lends itself to certain kinds of marketing, and has a marketing potential for certain people we can't normally get to engage with our quit lines, which I think is a great idea. The Freedom Journey Kit, the Path to Freedom Kit, you can read the whole thing. Those are good. And also use ChatGPT. So much fun. Thank you, Susan.
Chelsea touched on this earlier, but we have done a lot of research, market research with local communities and our priority populations, with conversations around rebranding the Colorado Quit line, which hasn't been rebranded in over 20 years. So we are currently in that process. And what we heard overwhelmingly time and time again is quit is so scary. I just want some more information. I just want to know how I can get connected when I'm ready to try, but quit makes me feel like I have to quit tomorrow. And that feels too final to me, and that's scary, and it's a lot of pressure. So we're trying to avoid quit, maybe focus on harm reduction, but we want to eliminate quit, but also choose a title that tells you what you're actually getting. So I love ChatGPT as well, and please spam me with all of your ideas.
Deb, did you have your hand up again, or did I just fail to lower it last time?
That was me. I just didn't put it down.
Oh, okay. Yeah. I also failed to put it down, so we're in the same boat. For the Breathe Easy bundle. Oh, is that in there? Oh, that's a good one. I like that one. Yeah, great questions. Other questions or concerns, especially those of you who are actively pursuing a quit kit program. Do you have any questions? Especially, I don't know, have you sat down with your POs and talked about the evaluation of those programs, and do you have concerns around evaluation?
I had just a quick question. I know we talked when we had our last meeting about having a way to target the quit kits towards kids, maybe women versus men, LGBTQ, just ways of taking the contents of that and adding or subtracting or modifying something to add value to those different populations.
Yeah, so there's always this, and I'll seek some comments from the STEP team too, but there's always this trade-off where you can make one quit kit that's sort of universal, and the benefit of that is time and money. It's going to be cheaper in both of those categories, but you're going to lose effectiveness because you're not tailoring it to certain populations. Once you start tailoring it for certain populations, you have I'm not saying don't do it. I think that you should tailor your materials, absolutely, and the evidence suggests that you should as well. But we do have to think of those trade-offs. So suddenly you're like, okay, we're going to have 50 of these that are LGBTQI plus, and we're going to have 50 of these that are for men, and 50 of them are going to be for our Latine population, right? Like suddenly you bracket it in, and if you don't distribute, it would be easy to get rid of 250 universal ones. It's going to be harder to distribute 5 sets of 50 to different target populations. And of course, you're going to add additional materials, because most of the materials you're going to start with are going to be, the way that I would be designing it would be designed for universal and then tailoring on top. And so you're going to be adding those materials. So those are also going to become more expensive. And the way you think about that from a business perspective is more expensive per quit gained. Which is all to say, you should do it, but it does take additional effort. But then, come to us. I happen to have a great resource for materials that you can print on your own for the LGBTQ population. And I think that you should be adding those. I would say that more than materials, it's the partnerships. If you want to get your quit kits into the hands of, say, the LGBTQ plus population, then find your LGBTQ plus leaders in your area, the service organizations that already have that audience, and work with them to be your distributor. It coming from them as a trusted tool is going to say more about its effectiveness for them than any materials you put inside.
I would agree. And to piggyback off that, ask them what would be super helpful in these kits for you and for this population, instead of just assuming like, put a pink pencil in a bag and now it's for women. Like there's probably better ideas. And if you ask the group who you're trying to work with and reach, it would be more effective.
Thank you. That makes sense.
We have about 5-ish minutes left. If anybody has any final notes, Rebecca, I also think that having tobacco or nicotine in our quit kit name is it's good from afar, right? I think that if you get if your doctor says, do you smoke, and you're like, yeah, and he hands you a quit kit, whatever you call it, it probably doesn't need to have tobacco in the title. But if you're advertising, marketing them coming over and get this thing, yeah, you probably want to have tobacco included in there somehow, or nicotine.
We also learned in our marketing research for the Quit Line rebrand that people under 50 generally don't relate to the term tobacco. I think one of my favorite comments was, tobacco is what my grandfather used to put in his pipe and smoke. I don't use tobacco. I use nicotine, which is technically true if you're using something like Zyn or an e-cig. So we're always trying to find that middle ground of incorporating all of the words that relate to people. What we currently land on is tobacco and other nicotine products, which does not roll off the tongue very easily. So
no, it does not.
Not at all. So we're still trying to find the correct terminology, which most people can identify with.
Yeah, and to Katie's point, you got to be careful around quitting nicotine, because we don't want to scare people away from nicotine replacement therapies, which is a problem that we have run across when we created our nicotine-free policy for organizations, because then you have to, if you say tobacco, you have to say except for sacred use. If you say nicotine, you have to say except for medicine. There's always some stupid caveat. We don't have a good word for what we want to talk about.
I will share one final thought that we've discussed, just in case it rolls around or comes up. When Jim and his team are finished creating their self-help quick guide that will be available via a QR code, the benefit of the QR code, A, is that it's less printed material, but B, we can run analytics and see how many times was this QR code scanned. So if you gave out 100 bags, we can tell you on the back end how many times that QR code was scanned. So are people actually engaging with the quick kit once you hand them out? And it offers a little bit more insight. Right now, we don't currently have a way to do that, but that is coming, and that is something that we have thought about so that we can provide better feedback to the grantees who are using these tools to say this worked really well at this event or with this group, not so much with this group.
Yep. Thank you for that. And Rebecca's asked how frequently these calls are, and the answer is at least once a quarter. And how frequently and what topics is up to you guys for the most part. Like, I wait for you to say, like, I'm getting a lot of questions about X, Y, and Z, or I have a lot of questions about X, Y, and Z, and then I will try to come up with a presentation or a guest speaker around that particular topic. There were a lot of concerns that came up at the end of last year around Quitline and Quitline data, which is why Quitline is next on our agenda, and talking about some outcomes and changes in the Quitline and all that good stuff. It'll be a nice big full discussion on that. And then I do other things in between that are less audience engagement, more webinar specific. And so I have recently finished a presentation on the tobacco cessation and use patterns for the Latinx or Latina population. And so that'll be coming down the pike probably near the end of the year, probably closer to December. So those are what's on deck for now. But if I didn't say something you're interested in, and you're like, I want to hear about this instead, get me. Also be on the lookout for, because something you all are interested in, all right, because I've already heard this, is on oral nicotine pouches like Zen, and myself and my director, Dr. Chad Morris, we are doing a presentation. It's going to be a live webinar. We're doing it through the hospital system, but everybody's invited. I'll send a note out for everybody, and that it's just going to be just on that. We're not including any other products in that webinar. So if you want to learn everything there is to know about ONPs, it'll be September 26th. And I don't remember the actual time of day that is, but that's the date.
We will highlight that in our newsletter, Jim.
Yeah, for sure. I've just been nervous about it because I haven't made the slide deck yet. I don't like to market materials until I have materials to market.
Fair.
All right, everybody. Thank you all so much. We're 1 minute. We did it. We went down to the wire. I appreciate your attention and your questions. You've all been absolutely wonderful, and we will see you in a couple months.
Thanks, everyone.